All right, we're going to go ahead and get started to make sure that Evan has enough time to present. I have the honor of introducing my co-chief today. Dr. Evan Sell attended undergraduate locally here at Macalester College and then went to Wayne State for medical school in Michigan, returned to Minnesota for his residency here in pathology, where he's a fourth year and co-chief resident. And following graduation, he'll be completing a cytopathology fellowship at the University of Colorado. Today he's going to be talking to us about thyroid nodules, although I understand we're going to learn about some other interesting topics as well.
Thank you, Sarah. So I've got a timely and interesting topic to talk about today in the thyroid, but before that I want, for my own enjoyment, to talk about a different timely and interesting topic. It may not have even dawned on you that something special happened this past Sunday at 7:51 a.m. And I actually snapped this photo about 10 minutes ago. But it was a sunrise, and what's particularly unique about it is that it's the latest sunrise we'll have for all of 2016. So that may hit you as not all that relevant, but also you may be wondering, hey, that's not the winter solstice, and I thought the shortest amount of sunlight we get in the day, get all year, would be on the winter solstice, so that should be the latest sunrise. Yet here I am saying that's not the case. So why do I have that nerve? Well, here first, just to show you that we've got sunrise, and by a few seconds, January 3rd is the latest, and we're still gaining sunlight. We're not at the solstice. To explain it, we're going to have to simplify our solar system a little bit. We've got sun in the middle. Earth, we're looking at it from over the North Pole, so the stars in the middle. Minnesota here is facing the sun, nice and shiny and happy. So I've got depicted here a quarter rotation, or about 3 months through our orbit. Now at any one time, of course, only half of the Earth is in the sunlight, the side facing the sun, obviously. And we rotate counterclockwise from this perspective. So Minnesota here in the middle of the day around noontime, night down here. So we can define sunrise as when we rotate into the sunlight. Noon is when we're looking directly up at the sun, and sunset when we rotate into the dark. So that's a useful definition to have, because we run into a problem. If we define a day as we might intuitively to a child as one Earth rotation, noon here is facing up on the screen, and noon 90 rotations later should still be facing up on the screen. Yet if your clock read noon here and noon here, you'd be looking at the sunset while you have noon on your clock. It would be a bunch of confused Minnesotans. That's not the case, though. A day is 24 hours, as you well know, but Earth rotation actually happens once every 23 hours, 56 minutes. You do some geometry, that 4-minute difference multiplied by 365 days yields you an extra 24 hours, so you get a freebie. By 365 sunrises, get one rotation free. And that 4-minute adjustment works out perfectly in a circular orbit, which of course we don't have. So here's just the concept that noon is up here, and our concept of noon shifts a little bit, although you can't really appreciate that when you're standing on the surface of the planet. So we don't have a circular orbit. We have a situation called an ellipse, where over the course of 6 months we start 94.5 million miles away from the sun, and we drop 3 million miles closer to the sun. If that sounds like a lot, it is. Dropping that kind of altitude will allow us to pick up some steam, namely over half a mile per second, and if you're not used to that kind of unit, that's over 67,000 miles per hour that we're cruising at right now, which is a good thing, because that's what keeps us from falling into the sun. What does this have to do with the sunrise? Well, it just so happens that the perihelion, or periapse, when we are closest to the sun and traveling fastest, happens January, actually this year it was January 2nd, not January 3rd. And winter solstice is just a few weeks prior to that. So we're in a situation where we're going faster than we would in a circular orbit. We start here on a circular orbit, we'd have exactly 1/365th of an orbit, but when we're going 18.8 miles per second rather than our average speed, we travel further, and thus Earth has to go a little bit further than 360 degrees to make up for that. And what happens then is that solar noon, defined as the midpoint between sunrise and sunset, gets later about 25 seconds each day this time of year. So here's just a little graph to describe what's going on. We've got midnight flanking the beginning and end of our day, sunrise and sunset, familiar concepts. Solar noon smack in the middle. How does this change over the course of a day between winter solstice and January 3rd? Well, we've got the Earth's orbit mechanics pushing everything later in the same way, the same amount, about 25 seconds. And yet the day is lengthening on both sides because we're after the solstice, these red arrows broadening our day. So solar noon shifts back, sunset shifts back due to two different forces, and these two arrows are competing against each other. The relatively static 25 seconds of daylight shifted backwards due to the orbit, and the expanding daylight due to us being past the solstice. And so for a period of 2 weeks after the solstice, the green arrow in Minnesota is actually a greater magnitude than the red arrow, so we get a later sunrise. Who knew? So hopefully that was novel to you, and when I learned about it, I kind of felt these general themes, which will apply for the rest of the talk, which is why I wanted to actually bring this all up. Namely, human beings are not well equipped to balance these abstract, simultaneous changes in different directions. We commonly confuse population-level trends with an individual trend, so a 4-minute adjustment works well on average, but not on any given observation. If you go out and look for when the sun is exactly due south, it'll never be exactly 24 hours from solar noon to solar noon. And lastly, things that you're familiar with and feel like you know by the back of your hand, often you just are familiar with them. So the objectives for the thyroid part of the talk. We're going to talk about epidemiology and natural disease course of thyroid carcinoma. We're going to hammer home some ultrasound, which I think is also not what we're commonly accustomed to in pathology, just like astronomy, but is really useful for us to understand. And lastly, speculate on how we could bring all of these kind of forms of data together into a single report that would be better serving our patients than what might be standard practice now. So I said thyroid is a timely topic, and I say that because in October, the American Thyroid Association unveiled a new set of guidelines, which moves the practice in quite a bit of a different direction. They've been adopted here at the university per my discussion with endocrine fellow. This 400-page document, which I spent most of my Thanksgiving break reading and digesting, was then published in a shorter form in the New England Journal of Medicine by Berman, first week of December. This is 8 pages, so I'd recommend you read that one. Also, on the timeliness of the thyroid, Nature had just kind of year-end wrap-up of things in science, and they published Science Myths That Will Not Die. And their number one myth, ahead of climate change denial and ahead of young Earth creationism, is the myth that early detection of cancer always screens life. Early detection of cancer always saves lives. And they talked almost exclusively about thyroid carcinoma. So why would Nature say such a thing? Well, first of all, I'll give you the kind of format for this talk. I'm going to follow it through the way a patient would, having a nodule but not knowing about it in the pre-diagnosis phase, having the nodule discovered, how we work up that nodule and make some medical decisions, and then how a report is eventually given to the patient and made into a decision. So when we're talking about a disease writ across a large population, or really in the field of epidemiology, so that's the field we'll grab onto first. This is the source of my initial interest in thyroid epidemiology, another New England paper from late 2014, and this is a South Korea experience of thyroid cancer screening. Around 1997, the government had an initiative to have more dedicated ultrasounds of the thyroid explicitly for the purpose of finding thyroid carcinoma. This aligned well with the financial incentives of hospitals, so they were happy to adopt this, as well as ultrasound technology became cheaper and higher resolution around this time. So the incidence, new diagnoses of thyroid carcinoma in South Korea went from about 5 per 100,000 per year all the way up to just about 70. That's a rise of about 14-fold. These two lines are close enough together you could confuse them for one line, but there are two lines. This is overall thyroid cancer. This is just papillary thyroid type. As you can see, all of the increase essentially is due to papillary thyroid carcinoma. And this down here, which you could also confuse with the x-axis, is thyroid cancer mortality, which is less than half per 100,000 per year, rather than 70, which is the incidence of new diagnoses. What's going on with this? They attempted to describe what might be happening using relationship between the density of CT scans, I'm jumping ahead a slide, The geographic province variation of uptake of the thyroid cancer screening, the dedicated ultrasound, versus how many new cancers were diagnosed in each province, you get kind of the best fit line. I wasn't entirely convinced by it, but conceptually it makes sense. The same line of investigation has happened elsewhere. This is data from the US, and using the SEER database as well as the National Radiation Protection Database, which tallies all CTs that happen in the year. They track how many CTs are done nationwide per year on the x-axis, and the incidence of thyroid diagnosis is further broken down into the size of the nodule. All sizes of nodules have increased as CT scanning becomes more prevalent, but the smallest ones have increased by far the most. Epidemiology trends going back just a little bit further than a few decades. In the 1930s, and again, I'm going to start a lot of surveillance epidemiology and end results data, because they've got wonderful graphs that I'd like to review with you. Using their data from 1935, thyroid cancer was predominantly a male disease. In 2008, it's predominantly a female disease. And that change in incidence amongst women from 1992 to 2000, which was 4.3% increase per year, was the highest of all malignancies tracked by this fairly exhaustive SEER database. What could explain the increase? Well, looking for an actual, increased burden of disease, there was a period from about 1910 through 1960 when radiation was a cure-all for just about everything. People would get radiation to the neck for reasons that would be laughable today. This petered out after the 50s, and by 1960s was done. So patients who would have been affected by this as a kid are, by and large, aged out of where we'd expect to have an increase to explain our current observations. A second line of reasoning would be this bottom point, that maybe we're just getting better at detecting smaller cancers, which would seem to make sense on a smaller time frame. From late 80s to 2008, the percentage of new papillary thyroid carcinomas that were less than a centimeter in size went from 25% to 39%. So let's talk about the cohort of people who get diagnosed with thyroid cancer. Just breaking down by age group, you see a relatively bell-shaped curve centered around age 50. I think it's worth pointing out that over a third of new cancer diagnoses on the thyroid are in people younger than 45, which is younger than a lot of other cancers we'd look at. Breaking it down by race and sex, again, women much more affected, men less affected, and there's some variation in the incidence of new diagnoses amongst race, but nothing overwhelming. I think this is one of the more powerful slides I've come across. So we've got 3 big data points that are worth looking at. The 5-year survival rate for people diagnosed in the late 2000s with thyroid carcinoma is almost 98%. That means there are just under 2,000 deaths per year and 60,000 new diagnoses. With a lot of people entering this pool of cancer survivors and not many of them leaving it, we have now 600,000 people living in this country with thyroid carcinoma, which is a mind-boggling statistic to me. How has that 5-year survival changed over time? It's always been pretty favorable, over 90%, and it's gotten better. So this could be either that we've gotten better at treating it, or that we're kind of diluting the pool of people diagnosed with cancer with people who have particularly indolent disease. I'll let you make up your mind on that as we go through more data. So as opposed to incidence of new diagnoses, mortality from thyroid carcinoma, it doesn't matter who you are. It's about 0.5 per 100,000 per year, which again, you can plausibly attribute to differences in diagnoses of indolent lesions more so than a difference in burden of disease. In contrast to age at diagnosis, people are much older when they die from thyroid carcinoma at the median age of 73. So our median patient would be diagnosed at age 50 and die of 73, or if he's like 98% of patients wouldn't die at all. So on to the survival data broken down by stage. The vast majority of people are diagnosed with stage 1 disease localized to the thyroid gland. For those people, survival rate at 5 years is 99.9%, which is pretty good odds. For the quarter of people who have nodal metastasis in the neck, still 98% survival. Even those with distant disease, and I don't know of another carcinoma that can have distant metastasis and still 5-year survival is a coin flip. Another just change in diagnoses of thyroid carcinoma, which we've pretty well covered already. And you might be wondering, we have good autopsy data. A lot of the best studies were published in the 50s, 60s, and 70s. And it's common to find quoted numbers of 25 to 50% of autopsies will have nodules present. I, no joke, yesterday had an autopsy with a 2.5 centimeter thyroid nodule, someone who had plenty of other cardiopulmonary problems to kill them. So it's not going to be the cause of death, but it's probably going to be papillary thyroid carcinoma. So with 20 to 50% of people having nodules, it's 1 to 5% of people who have carcinoma once you extensively sample those nodules, which is a very high number, but not too far off from the 600,000 people that we know have thyroid carcinoma in the US. So you might be wondering, if so many people are walking around with carcinoma and dying of other causes, what would happen if someone wasn't treated? There was a group in Japan who had the same idea, and for carcinomas less than a centimeter in size, just observed them with close monitoring, ultrasound every 6 months. About a quarter of these people over the course of 10 years did have a thyroidectomy, even after the diagnosis of cancer, presumably due to increase in size of the nodule or just because of patient preference, and they opted out of the study or went to a different hospital. 3% of these patients had nodal metastases over 10 years, and only 15% had actual increase of the size of their nodule by more than 3 millimeters, which is a pretty stringent cutoff. Some further review by ultrasound experts more closely affiliated with the study had them tailor this 16% figure down to about 10% who actually had true increase in size as opposed to just kind of variation in technique of measuring. So that's what we've got for epidemiology of a fairly indolent lesion. We'll talk very briefly about how thyroid nodules are discovered quickly. And the single word to describe how thyroid nodules are discovered now would be incidental. And this is not a newly recognized phenomenon. This paper is from 1982. Patients who had ultrasonography of the neck looking for carotid atherosclerosis were found to have unsuspected thyroid nodules 13% of the time, even back then with outdated technology by today's standards. This is a study from Duke, and we'll return to this group's work later, tracking that it used to be the case everyone diagnosed with cancer came in because they had hoarseness of breath or some kind of clinical symptom, and increasingly a larger share of people have the thyroid removed for other purposes, the incidental cancer by pathology, and are found to have small foci of thyroid carcinoma, or they have CT scanning for, say, trauma that might involve the neck and are then found to have a nodule which is worked up subsequently and eventually found to have carcinoma. So this is just restating that it used to be clinical disease that brought patients in for a diagnosis of papillary carcinoma. Increasingly, it's someone who has no complaint about their thyroid or their throat that leads to incidental imaging, which shows a nodule. And for prior to October, with the new ATA guidelines, the rule was anybody over with a centimeter or larger nodule would get an FNA. So now we're on to the investigation phase in our generic patient moving through from having a nodule, not knowing about it, to making a decision about how to manage it. Ultrasound is one of the first steps. Ultrasound is a highly useful modality. It's non-invasive, no radiation exposure, relatively inexpensive, and it answers a few key questions for someone with a newly discovered thyroid nodule. Presuming our hypothetical patient had a incidentally found thyroid nodule on some other imaging, does that nodule incidentally discovered correspond with what we have on ultrasound currently? How large is the nodule? This is still a major factor for management. What's new with the ATA guidelines from 2015 is that the ultrasound imaging characteristics are incorporated into the decision making. Cystic nodules are managed quite differently than solid ones. You can get some staging information just based on ultrasound with cervical lymphadenopathy, and management is also different based on posterior position of the gland, of a nodule within the gland, because those are more difficult to monitor accurately and also more likely to cause a problem with the airway. So let's talk about some of those sonographic features. These are new, and I think increasingly as we sign out an FNA of a thyroid, we'll want to know some of what happened within the ultrasound. So things to look out for are composition. The body of the nodule itself, is it solid? Does it have a large cystic proportion? And is it spongiform? Echogenicity is the kind of intensity of the coloration as we look at it relative to the surrounding normal thyroid. Margins can be smooth and round. They can be irregular. They can even be spiculated and infiltrative. Calcifications presence is self-explanatory, and shape, as with ultrasound of the breast, taller than wide is a bad sign in that it is infiltrating through fascial layers. Vascularity, there's plenty of literature on vascularity of thyroid nodules as assessed by ultrasound. The ATA guidelines from 2015 do not emphasize the study of vascularity. And so here's the 6-tiered reporting system for thyroid nodules as endorsed by the ATA. I'll just kind of point out these percentages for estimated risk of malignancy. If these look familiar and kind of overlapping with what you'd see in the 6-tiered Bethesda FNA reporting criteria, I agree with you. And here's our kind of picture from 10,000 feet, and we'll zoom in starting from the bottom here. So purely cystic lesions are by definition benign. Very low suspicion lesions are either spongiform appearance, and for me as a novice, I'd say this is a harder pattern to pick up relative to some of the ones we'll see later. Distinguishing spongiform from those could be a little bit challenging. Progression from pure cystic to partially cystic gets you up to a very low suspicion. Likelihood of malignancy on resection about 3%. Changing from cystic lesions to hyperechoic lesions with solid regular margins, we get into low suspicion. Or if it's a partially cystic lesion, has kind of an eccentric aspect to it that doesn't quite fit as a clean partial cyst, also low suspicion. Intermediate suspicion, a little bit higher. We change from hyperechoic to hypoechoic, but we've still got solid regular margins. And to go beyond that, you need something other than solid regular margins. So we're into microcalcifications. And here I think there's potential for overlap with a spongiform pattern depending on user expertise with a particular probe. Hypoechoic irregular margins, taller than wide, lateral lymph nodes that are present in anything involving the nodule and outside of the thyroid will get you into the high suspicion category, which is predicted to have a 70 to 90% likelihood of malignancy on resection. There's some interesting data on the relationship of size, and we'll talk about exactly how the ATA stratifies size to manage patients. Older patients, according to one data set, are more likely to have lesions that stay small, but you can find just about anything you want to say about the relationship between age, nodule size, and mortality based in the literature. It will go any way you want. So ultrasound has a number of strengths, as mentioned before, and can tell us a good deal. What are some of its shortcomings? The statistics I gave you for prediction of malignancy on resection are based on one patient population at a large academic center that may not be applicable to a given institution. The imager, the actual ultrasound probe, has changed quite a bit even over the last 5 years, and staying up to date with that may not be cost effective for a smaller institution. Technique in ultrasound is well known to differ based, it's a handheld instrument with a lot of user input, and that the outcomes differ based on the experience of the ultrasound tech. And interpretation differences, even the same set of images, can be read differently by different radiologists. So there are a number of guidelines on how best to implement a generic ultrasound classification system like the ATAs. And coffee has just arrived, so in a few minutes people can start looking backwards. The best practices are widely varying based on a number of guidelines published in the last 8 years, and probably they're coalescing around the ATA guidelines from 2015. So here are those guidelines for management. Again, this is the higher up view. This is actually from the shorter Berman article published in December. And we'll start off at the top. I'll put an asterisk next to incidental thyroid nodule. The ATA specifies incidental nodules are managed differently than would be something picked up because someone comes in for screening, say for family risk of thyroid carcinoma, or because they have symptoms related to it. In any event, the next step in workup is history and physical, again trying to rule out family predisposition. TSH is used in the next kind of stratification level, and ultrasound is implemented early as it's a non-invasive technique that can provide us a lot of information. So let's follow our algorithm down for someone with a low TSH. Their next step is to get nuclear scans, and if they show a hyperfunctioning nodule, they're essentially treated for hyperthyroidism as clinically indicated. For someone with the nuclear scan that shows a non-functioning nodule, they are managed with FNA if the size warrants. And so I threw that little asterisk again by the FNA if nodule greater than 1 centimeters. The Berman article says stay with FNA if nodule greater than 1 centimeter. The ATA guidelines are less FNA happy. For someone with high risk or intermediate risk ultrasound features, FNA of greater than 1 centimeter remains. For someone with low risk ultrasound features, so again in the 5 to 10% range, the nodule has to grow up to 1.5 centimeters before warranting a nodule, before warranting an FNA. And if the nodule's very low risk features on ultrasound, the ATA guideline is wait until it's 2 centimeters to sample it. So back to our guidelines. We looked at the low TSH arm earlier. Here's the high or normal TSH level. So they go straight to the FNA based on size. And once we're into the FNA, we're into the realm of morphology, again, in working up towards a clinical decision. And with FNAs, again, we have a 6-tiered Bethesda reporting criteria, and here are the options in our multiple choice exam. If the FNA is reported as non-diagnostic, the management is to repeat. If ultrasound guide wasn't used the first time, it should be the second time, although here we standardly use ultrasound for all FNAs of the thyroid. A nodule that warrants FNA and gets a diagnosis of benign will be monitored with ultrasound based on the clinical level of concern, anywhere from 6 to 24 months to repeat that. And if that monitoring shows greater than 50% growth, it warrants a repeat aspiration. We get into this indeterminate category once we're into atypia of undetermined significance or follicular lesion of undetermined significance. The ATA guideline is for low suspicion lesions, and they provide exhaustive, about 20 pages of explanation on what qualifies as a low suspicion lesion. They get a gene expression classifier, And for high suspicion lesions, they get mutation or rearrangement analysis. And we'll talk a little bit more about those later. So beyond the realm of indeterminate lesions, suspicious or malignant criteria would warrant a thyroidectomy. Some suspicious lesions based on location of the nodule may be referred for hemithyroidectomy. But the change in the latest guidelines is that suspicious lesions are more likely to go to full thyroidectomy. And lastly, the more confusing follicular neoplasm, also an indeterminate category, would be eligible for lobectomy, thyroidectomy, or additional molecular testing. This is just a review of cytology and the Bethesda classification for thyroid nodules. For the residents, this is probably something you've encountered more than you care to admit. And I'll highlight these risks of malignancy and kind of compare them to what we had just based on ultrasound characteristics alone, ranging from the less than 3% to 10 to 20% based for low suspicion ultrasound features, and we get to the more suspicious lesions, which matches up well whether you're reporting based on FNA or ultrasound characteristics. This is taken from the 2009 Bethesda paper. The purpose of terminology is clarity of communication. It used to be there were several classification systems. A report from one pathologist may use the same terminology but mean something completely different, which was terribly confusing for clinicians. So our interpretation should provide clinically relevant information that will assist referring physicians in the management of patients. Increasingly, we're getting more information on these nodules, and I think it's our duty as pathologists to incorporate that as it is clinically relevant information and has an impact on the management of patients. As to what Bethesda, the original classification, says on how to manage based on size, this is not from the Bethesda paper, but from the main paper that generated the predictive numbers that we saw just a couple slides ago, and has some of the same lead authors, Sebas amongst others, that would eventually write Bethesda. They say they admit there's no long-term benefit known for detecting small papillary cancers, but it seems like a good idea not to wait till 1.5 centimeters. And they cite as justification a 1994 paper, which had the most impressive follow-up data I came across in my literature review. This was from Ohio State University and the Armed Forces Institute of Pathology. They had a lot of 30-year follow-up on patients, and these were not observed like the Japanese study. These were managed. For 30-year cancer mortality, 8%, and they being partially about 2/3 of their population came from the military, so they were skewed towards younger people. They had a median age of diagnosis of 35. But again, a third of nationwide thyroid cancers are diagnosed in people younger than 45, so they're not terribly skewed. They describe only a reduction in mortality based on aggressive treatment for tumors larger than 1.5%. So going back a second to, hey, we should probably treat aggressively before 1.5 centimeters, struck me as a little misreading what the original authors had said. How does Bethesda classification system perform in real life? It performs about as advertised, is the short version of this table. I won't go through it individually. And what happens based on the cytology result? We have a built-in management recommendation. How often is that followed? This is, again, from the Duke group, and they showed when they actually went back and followed up the management of their patients, 25 to 40% of their patients who had FNA for an incidental thyroid nodule went on to surgery. Once those nodules were removed, about half, with a broad range of possibilities, were benign. So we're going to skip ahead in front of molecular for just a little bit because I want to talk about how we report these things. And I want to talk about Thomas Bayes. He was a 18th century Presbyterian preacher. He was also known to be a gambler. And it was that love of gambling that made him think about statistics a little bit harder, because he grew tired of just praying for an advantage on the poker table. So he didn't actually publish this, but people after him used his work to publish this, and he gets credit for it. And Bayesian statistical reasoning is a change in perspective to what we might have as a binary, positive or negative result. And it restates a test result as not an answer, but rather a transformation in someone's likelihood of having a condition. So we have a pretest probability based on largely epidemiology and initial history physical gathering. The test gives us some amount of transformation, and we end up with a posterior probability, which will hopefully be useful in management. The magnitude of that test transformation depends on familiar concepts like sensitivity and specificity. I would bore you with the equations, but I already did the orbit thing to start the talk, so I think you're done. And what's important is that you don't just get one test. You can use multiple of them, assuming that they're unrelated and they're testing different orthogonally related attributes. Which is really useful in a game of chance where there are strict rules, but in biological systems where we have imperfect tests, it gets messy quickly. I don't know that I have enough time to share my amusing anecdote from this book, but it's a great book. You should think about it. So I'm going to recycle a graphic here, and so instead of daylight, we've got dark here, which is areas where they don't want pathologists' input, and that's sad and dark. So flanked on certainty by both sides, it's either 100% this patient definitely has the condition, or 0% there's no way they have it. The critical transitions, instead of sunrise and sunset, are threshold to test or threshold to treat. Someone down here, it's so unlikely that they have it, I'm not going to bother investigating it because any positive result probably doesn't mean anything. Here, I don't need to wait anymore, I'm just going to treat, and on rare occasion I'll be wrong, but it's worth it. I would be wasting time and resources if I work them up any further. So the concept of Bayesian statistical reasoning is that you have a patient and you know something about them, and it's important that you think about who they are and come up with some vague pretest probability. You have your test result. It's either positive and moves you right. The magnitude of this change depends not on orbital mechanics and the winter solstice, but on the sensitivity, specificity, positive predictive value of that test. And the posterior probability is what you end up with. If you start in this blue zone and end up in this blue zone, you're not ready to manage your patient. You need further workup. If, by contrast, you start with the same pretest probability and you have a negative result that is of a large magnitude, you end up underneath your threshold to test, and you've arrived at your management decision. So I think a key point I want to bring up in distinguishing between the ATA guidelines and their distinction in how you manage incidentally discovered thyroid nodules versus any other kind of discovered thyroid nodule. They found, this is again more of the Duke group, that cancers that are found incidentally are smaller and less likely to metastasize. So to put that in perspective, here is a table with their data for incidentally discovered carcinomas. The nodal disease was present in less than a quarter of their patients versus people who came in with a clinical problem that warranted investigation of their thyroid. It was more than a third who had nodal metastases and even 1% who had distant metastases. So if you know that you're in the incidental cancer discovery group, your outcomes are going to be here, which should really change how you initially think about your management here. And I'd argue that for a lot of our incidentally discovered thyroid nodules, they're probably to the left of our threshold to test. So now we can return to molecular, because I think it's useful to have some of the baseline Bayesian reasoning to have this molecular results incorporated, which are often towards the end of a workup. So the role of molecular, as stated in the ATA guidelines, you have either mutational analysis, which is the Thyroid product offered from Pittsburgh. There are also several off-brand versions of this testing. These are highly specific. In contrast, we have gene expression classifiers, namely Afirma, based out of Texas, and this should be up there. Gene expression classifiers are more sensitive than specific. The mutational testing is really based on RAS and BRAF. Apologize for that. So how do mutation testing results work out? The pertinent mutations involved are typically RAS, BRAF, and a smattering of others. And this just breaks down the likelihood of useful results based on what the input cytology result was. So for AUS, you have a 99% specificity and a very useful positive predictive value. And this doesn't change hugely for follicular neoplasms. For suspicious malignant cells, you have a higher pretest probability of disease, and indeed the positive predictive value goes up. So this is not the mutational analysis. This is data put forth on the gene expression classifiers, and again shows the impact of pretest probability on your positive predictive value. So these are sensitive. They're designed to rule out the likelihood of malignancy, and so we're really concerned about the negative predictive value. And it's important for clinicians to know when they're ordering this test, if they have a very low pretest probability, the negative predictive value is good, but saying that before the test was ordered, you had about a 10% chance of malignancy, and after you have a 2%, isn't terribly informative from my perspective if I were in the shoes of a patient. Furthermore, I'd be looking for a reason to treat rather than a reason not to treat, because my default would be I don't need treatment if my likelihood of malignancy is low, and the likelihood of that malignancy, if present, causing problems is lower still. That's my perspective. So again, the role of molecular, the highly specific testing, mutational analyses are currently billable to patients. Thyroid uses a $2,500 billable to patient. For our internal studies, and I believe I have this figure right, is about $618 billable to patient for our own mutational analysis. Afirma has been clever enough to get their testing reimbursed by most payers, whereas essentially no insurance payers will pick up the cost of mutational analysis. So our Holy Grail, kind of putting all of this information together, is that thyroid cancer screening involves several specialties. It could be family practice, who initially uncovers a problem, radiologists who work it up, endocrinologists would get involved before FNA presumably, pathologists are obviously involved, we've got separate molecular labs, and having one common reference point for converting these results as they bounce back and forth between different specialties and often different institutions would allow us to keep perspective of what's really going on. Just like it's nice to keep perspective of what's really going on to account for why the sun rises at a certain time. It's a relatively high volume that we have in thyroid cancer screening. Again, 600,000 people have already been diagnosed with carcinoma, and the majority of people who have been FNA'd were found to have benign lesions. So it would be worthwhile to come up, have a high investment upfront cost to come up with a strong integrated report. And lastly, compared to a lot of other lesions which recur and have to be managed in a very complex algorithm, thyroid cancer diagnosis is relatively simple. It's a lot of multiple choice answers, with 6 possible options. And so coming up with an integrated report is probably more doable in the thyroid realm than a lot of other cancer screening scenarios. So with that, I'll review my objectives. We talked about the epidemiology of thyroid carcinoma. We talked probably more than you cared to know about ultrasound. And we talked a little bit about ways to come up with different modalities into a single report that a patient could understand. So with that, I thank you. Rupendra was the endocrinology fellow who had some useful input for me. Dr. Nelson and Dr. Amin were both useful in putting together the talk. Happy to take any questions.
Thank you, Evan, for a very good presentation. Just for clarity here, the epidemiology discussion we went through, I assume that every time you refer to thyroid cancer, or the literature refers to histology, the histologic diagnosis of cancer rather than FNA.
Correct.
Because, as you know, over the years, the criteria for diagnosing microscopic histologic diagnosis of cancer, especially papillary carcinoma, moved a lot. Actually, it's a moving target. On the one hand. On the other hand, pathologists' attitude towards diagnosing cancer also shifted.
Right.
As you probably know, anatomic pathologists in their heads somewhere, even though they refuse to probably acknowledge this, that we think that we want to make a diagnosis that stays valid and correct if another test is done, which usually the other test is surgery or lymph node or whatever. So the unique thing about papillary cancer here is that nothing is going to happen. In other words, if I overcall papillary cancer diagnosis, there is no other test that can prove me wrong.
That's true.
So I know that you asked the question and you didn't answer it up front about whether we are even though you cleverly avoided the word overdiagnosing. My personal bias is that pathologists out there are overcalling papillary cancer.
I'm inclined to agree, and I mean for accountability purposes, I'd say the FNA diagnosis does have accountability in that the resection specimen, if it shows to be completely benign, the person with the FNA doesn't look great. However, we always couch it as, well, this is suspicious, so only 70% of the time when I call it would you actually expect to see malignancy on resection. So our stakes are a little bit lower on that side, and we put up with a 50% benign resection result, which, I mean, it's a comparatively benign procedure. We can talk about resource expenditure, but about 5% of thyroidectomies end up with some kind of significant complication, be it hypocalcemia because the parathyroids were involved, laryngeal paralysis because recurrent laryngeal nerves are involved, and even hematomas are possible in a highly vascular organ that's right next to the windpipe. They have a high morbidity, but are luckily very uncommon. So I agree. The stakes are relatively low, but the negative effects are other than negligible.
And that's exactly my point. Cytopathologists are very strict on for the application of their criteria, and because there is another test that comes after that that can validate their diagnosis. But for surgical pathologists, I think we overcalled it.
Probably.
So what are you going to recommend when you're a pathologist when you're trying out cases and you have a classic AUS?
I'd probably stick strictly to the ATA guidelines, and I think this is an important example of why it's good to have a relationship and a tumor board where you can discuss the nuances of some of these and say, well, I was really waffling, but you guys were pushing it for this reason, so I flipped a coin and said it was positive, or otherwise convey the nuances, and make sure that results that we provide and have a management guideline aren't being used in a way other than what we intended. I think it's that relationship with the clinicians that really drives how we do it. I would rarely push for more aggressive procedures, and as far as which molecular tests are most useful, I'd say my default is no treatment unless there's a really good reason to treat. I think that scenario is better addressed by mutational analysis than by the gene expression classifiers.
I'm not a cytopathologist, but I can tell you that every talk that I've heard from a cytopathologist in the past 2 years pretty much has addressed molecular testing of AUS or plus diagnoses. So I'm not, I understand the pretty rigid criteria for making those diagnoses. Just in this institution alone, the management of those diagnoses has changed as far as complex molecular testing is done. And I think your clinicians here and elsewhere are going to be looking to pathologists to see what is recommended, what test is done. And I know that sometimes, at least now, we're hamstringed by the lack of reimbursement for the mutation analysis, but I think it is pretty clear that that's the better test right now. What do you think?
I definitely agree that the mutational analysis would be a better test. We have to, I guess, allow the insurance companies to catch up with this with science. So,
and I know Ruben and I know Maria Vosovich and Lynn Burmeister have worked hard on this, but I mean, this is a prime example of where testing needs to be thought of in cost-effectiveness model across the system, especially as we move to more of an accountable care organization. I mean, the cost saving that you get from having a more appropriately planned surgery after, mutational testing that guides it. I think that the key is not as much figuring out what's the sensitivity, specificity of the test as much as can you provide it at a cost point that allows for more effective patient management that is safe to the patient, beneficial to the patient, and cost effective overall to the system. And I think that's where there needs to be more data out there. I mean, a few of the cost analyses have come out of Pittsburgh. The problem is all the data on mutational testing, for the most part, has come out of Pittsburgh. It's something that Holly and I have talked about extensively. We need to get more data out there from other institutions that show the effectiveness in different patient populations and really focus on how that can change cost-effective patient management as well as quality patient management, since it is such an indolent disease.
All right. Thank you.